veneers, some indication and contraindications to treatment, clinical and laboratory performance of porcelain laminate veneers. So we start from some definitions, because veneers are mainly made to improve aesthetic. Because it's a prosthetic restoration that is fixed cemented onto the abutment tooth, but we rather do it when patients says that her or his teeth are not aesthetic. For example, we have diastemas, and maybe we have some non-aesthetic restoration, composite restorations, etc., discolorations. So mainly the reason that the patient come up with to our office is lack of aesthetic. So we need to know how to improve that situation. So we must know where is our goal, where is aesthetic, how we can find aesthetic in a patient's smile. So we need to know some definitions. And first of all is color. And what is it? So in order to effectively and efficiently meet the challenges of choosing the color of dental restorations, it is necessary to learn the principles of color art. This is a difficult task because color is an abstract and subjective concept. So we will discuss basic concepts related to the color. And translucency is not addressed in Mansell's color analysis, but it may be the single most important factor in the ultimate result of an aesthetic restoration. When restorations are labeled as too opaque, marble-like, or dead in appearance, the aesthetic limitation is generally the result of inadequate reproduction of translucency. Translucency, in effect, is the three-dimensional spatial relationship or representation of value. And here you have a scheme which shows us what is translucency, what is value, chroma, and hue. And here we have another picture which shows us the hue. And the hue is simply the color tone, for instance, like red, yellow, blue. And the term hue is synonymous with the term color. So we have a different hue, we have different colors. Then we have chroma, and chroma is the intensity or saturation of the color tone. Already we know that it's a hue. For instance, light blue or dark blue. It is used to describe, for instance, the orange or yellow hue of a tooth of a restoration. And now value is the relative lightness or brightness or darkness of the hue. And translucency is three-dimensional lightness. In general, the highly translucent teeth tend to be lower in value, for example, since they allow light to transmit through the tooth and pick up the shadows and darkness of the oral cavity and surrounding environment. So when we have black label behind our teeth, we know that are much lighter because of highly translucent enamel, for example. More opaque teeth allow less light transmittance, and they are more reflective in nature and therefore appear brighter, like previous. Here and here. We think that are more lighter, but isn't it? The opaque, that appearance of a restoration should be avoided. Metal ceramic crowns, for example, has the opaque. So it looks not so natural that we want. That's why maybe this is one of the reasons. That's why we rather in nowadays or nearest future we rather avoid metal ceramic restorations, especially in front aesthetical area. And the goal of an optimal restoration is to achieve the natural appearance of the tooth. For instance, metal ceramic crowns. Now, the redness or inflamed gingival tissue, for example, distorts our color perception. This phenomena has a significant clinical importance. If the shade is taken while the gingival tissue are inflamed, the tooth will appear to be lighter and the color selected will be too dark. Next thing is area contrast. Visual color perception is also influenced by the size of the object. A large size object will appear lighter, a small size darker. Like this picture shows. And here you see the example of area contrast as perceived in maxillary central, which is larger and brighter, and lateral, smaller and darker incisors, even though the crowns are the same shade, in this case A2. They appear much brighter since they are physically much larger. So everything is about perspective. And the clinical representation of the light or dark contrast you see on this picture. Postoperative view of the maxillary central incisors restored with the ceramic veneers. And notice that the translucency of the incisional edges against a dark background. And using a translucent layer during the laboratory stage can enhance the depth and vitality of the veneers. With adequate communication of information from the clinician, a skillful laboratory technician can judge the amount of translucency porcelain that should be applied over the veneer surface, especially in the incisal edge. So this is the individual characteristic that we want to have. So we should pass those informations, many of them, to the technicians, especially the photography. A common mistake during this procedure that is made by the most dentists is to dry the prepared tooth surface before taking the stamp shade. However, due to the phenomena of dehydration, the color of the remaining tooth surface will appear lighter than when they are wet. So usually we start, or we choose our shade before we start doing preparation. So firstly we choose the shade, and then we can go with preparation, because later in opposite direction then our color could be lighter, so more bright, and won't fit. And what about systems? Because our eyes are only our eyes, and when we have something digital, like digital machine, or in this case Shofu shade eye, we can choose digitally, and save that result, and patients can see. So this systems was invented in 1998, so almost 20 years ago, which uses a single point source spectrophotometer as the base of the shade analysis, marks the emergence of technology based systems for determination of shade for fabrication of the dental materials. Here you see the result from this digital machine. So we have something like picture, which shows us a strict tooth with the shade on it. Yeah, and we can put some photos to our history of treatment and pass those information to our laboratory, and technician can simulate the same shade in his or her work. Now a few words about indication for prosthetic veneers. So there are many of them, but as I said at the beginning, mostly are strictly aesthetic. So first, closing of free spaces like the stimas and trimas. Second, correction of small displacement of the tooth like rotation, crowding, etc. Third, lengthening of clinical crowns, improving the shape of teeth. Fourth, rejuvenation of appearance of teeth. Fifth, correction of tilted lingually. Sixth, improving the shape of teeth after orthodontic treatment. And seventh, changing the color. And next thing we need to focus on is golden proportion. What is it? For example, if the golden proportion has to be followed strictly, the ratios between the widths of the incisors should be like 1.618 for the central, to 1 for the lateral, and 0.615 for the canine, like the picture shows you. And the author suggests using those numbers and proportions only as evaluable parameters, since in real life, symmetric and proportional smiles hardly ever exist. So there are some indications, and the technician should prepare something like this. Yeah, not strictly, because it could look artificial, but more or less. The teeth, lips, and smile should be observed and evaluated from different angles. So not only from the front, but also from lateral side and occlusal plane, etc. The dental midline is placed on the imaginary line, which is actually the facial midline in 70% of cases. The midline can be slightly deviated to the right or left when the lips field room is used as a reference. This is true for over 40, I guess, or 30% of the population. Slight deviations do not create visual tension, nor do they affect the aesthetic negatively. A high percentage of the patient, about 75%, have mandibular midlines that do not coincide with the maxillary. So, in nature, the perfect symmetry almost doesn't exist. And even, as I said, it looks quite artificial. A slanted midline or a dental midline that is placed obliquely in relation to the facial midline will always distort the symmetry. Even when placed in exactly the correct position, it looks even more unpleasant when it is slanted and shifted to the side at the same time. The classic chart from Lombardi illustrating the SPA factor. So SPA is sex, personality, and age. Every characteristic of a single tooth may carry evidence concerning the patient's SPA. However, When designing a new smile, factors such as cultural background, the expectations of the patient, and their lifestyle, as well as the dentist's artistic ideals and values are to be taken into consideration. So you see, we have two ways in age, like age or young. We have two ways of sex. It could be feminine or masculine, or personality, which could be soft and vigorous. And the appearance of left and right tooth are completely different. And this diagram showing the inverse proportion of the tooth display between the maxillary and mandibulary incisors related to the age. As people age, less incisal length is displayed. The reduced display is owing to the sagging of the upper lip, and the reduction is further increased by the incisal tooth wear. In the mandibular arch, even though same incisor wear doesn't exist, the lower tooth display increases as the muscle tone of the lower lip decreases and sags down owing to the gravity. Yeah, so combined with age, we shows more lower teeth than upper teeth. So this is unfortunately nature. Now smile line. Low lip line with relatively short teeth. It is not possible to see the teeth when lips are the rest or half smiling. The short length of the maxillary anteriors and the silicon index from the worksop indicates how the teeth should be elongated. The teeth are covered with aesthetic prevaluative temporaries, which is in short APT, before the actual material preparation, which is AMT. The patient can now visualize the new length and the color of the teeth, and the preparation is done over the APT. Finish porcelain laminate veneer and their relation to the upper lip. Please note that even in half smile, the incisals of the anterior incisors can easily be seen. Yeah? The lip support of the porcelain laminate veneers, the upper lip stays retruded before the restoration, the very positive impact of the new smile on the face. Yeah, so we see. In a pleasant smile, the incisal edges of the incisors follow convex curvature, which is parallel to the lower lip. The lower lip in men is fairly straight, like picture B. When compared to the female lip, picture picture A and picture B. B is women, A is men. That creates a smile line that is flattering in males. And the level of the upper lip line must be evaluated while at rest, when talking, and when smiling, as the level of gingival display and visible tooth surface are affected by these various positions. The incisal edge and lip line must be in harmony. It is generally accepted that high lip lines are less favorable because they display more gingival tissue. The cervical gingival line is also important, and in the case of high lip line and the resulting asymmetric problems need to be dealt with accordingly. And now a few words about story-taking, about documentation, is photography and videotaping. High-quality photographs, in addition to a full examination, are must for aesthetic evaluation process. These photographs are not only important for communication with the laboratory, but also to help the dentist clearly to evaluate some of the details that might have been missed during the naked eye visual examination. However, these tools may not be sufficient for the in-depth evaluation of a smile. If the dentist wishes to go one step further, then the use of a video camera will be enabled for him or her to record the patient's teeth and their relationship to the lip line and face while smiling, talking, etc. To catch a natural smile in a photograph may be difficult or even forced, whereas through the use of the video, the patient will eventually relax and allow these relations and the range of facial expressions to be observed in a more natural setting. With the introduction of digital video cameras, one can freeze any frame and easily print out the picture. This is a great communication tool not only for the dentist and patient, but for the technicians as well. And sometimes the lips may exhibit unusual characteristics such as an irregular upper lip line, a high or low smile line, or overly thick or thin lips. These characteristics must be evaluated and explained to the patients in accordance to the treatment plan that is to be undertaken. The movement during function and the amount of visible coronal portions of the teeth and PLD are very important in the planning stages for the prosthetic treatment. While closing a diastema, both dentists and patients should review the final outcome before the final restoration are made. Composite mock-ups are simplest and fastest way to achieve. In this way, the end result can be seen from the first appointment. The patient gains a full perception, including the triangular shape of the papilla between the teeth involved. The final restoration mimics the contours of the composite mock-up. Through natural integration, teeth look extremely natural. The length of the teeth and the incisal edge position will will determine the levels of the gingiva. At times, the gingival plane may not be parallel to the interpapillary line, and therefore natural asymmetry is often exhibited, or at times asymmetry of the gingival tissue may exist. This is especially true if there is a case or high or medium lip line, and so their alignment must be incorporated into the treatment planning. If the gingiva is visible when in full smile or during speech, incisal and gingival planes must be harmonized with the face, of course. And here is the technique. So a flowable composite, for example, luxatem, structure, or etc., is then loaded into the translucent silicone template and placed over the prepared teeth. Yep. And depending on the difficulty of the case, it takes from 5 to 20 minutes to prepare the new smile design with composite mock-ups for the whole upper arch. The easiest way of doing the mock-up is with the freehand carving method. The composite is rolled between the fingers and applied over the dried tooth structure. It is shaped with the help of fingers and special hand carving instruments, and then light cured. The teeth can be length or protruded, or the color can be altered for the patient to visualize. And after placing the composite mock-up on the tooth, if any part is exaggerated, in other words, if too much composite is applied or polymerized, in this case, as you see, they should be cemented with either a flowable lutein resin or eugenol-free cement, the temporary. And partially, to bond the professionals in place, teeth are spot etched. The important issue is to try to keep the spots on the same horizontal level. This thing will ease the cleansing of the bonded area just before actual restoration bonding. And the tooth is then covered with adhesive, of course. So this is a picture which shows you a spot etching technique. And here we have the picture which shows you a facial reduction with indication reel, which you already made. This is a facial reduction of 0.5 millimeters with chamfered margins and 1 millimeters of incisal reduction, are preferable considering the conservative nature of veneers preparation. So you see, so we work only with two parts of this drill, not whole at once, so we must tilt. And picture A shows you the depth cutters are used through the APT. This will provide the dentist with the minimal invasive preparation. Picture B shows you the APT after the depth cutter is used. Note that the remaining parts would have been uselessly prepared if the APT was not used. And C, the horizontal groove produced through APT, and notice how shallow the grooves are. So this is almost uninvasive technique. And coating the surface of the tooth with a water-insoluble tint allows the depth or horizontal grooves to be more easily perceived. Notice that the horizontal grooves hardly reach to the distal of the central and mesial of the lateral. Any unnecessary entry is prevented by the preparation done through the APT. The round-ended Fisher diamond burr is used in 3 different planes until all the color and at the surface of the bottom of the grooves disappear. This will indicate that the true actual material preparation depth is fully achieved. And here we see there are 2 basic techniques for the placement of the incisal finish line. The first terminates the prepared facial surface at the incisal edge. There is no incisal reduction or prep of the lingual surface, and it can be in the form of a window or intraenamel preparation, or the further incisal preparation. In the second technique, the incisal edge is slightly reduced and the porcelain overlaps in the incisal edge terminating on the lingual surface. And here you see the indexes. We can control preparation using a silicone index, of course. And last step of the preparation is rounding at the edges only. And here is provisional drying procedure. The veneers should be first dried in before they are bonded to eliminate unexpected surprises. Steps for treating the inside of the PLV and tooth surface just before bonding. Yeah, so the different treatment is applied on the veneer and the different on the tooth. So on the tooth, usually is like for conservative, so it's etching for 30 seconds and adhesive, but they not to light cure. But the different, but the veneer surface is etched with hydrofluoric acid for 30 seconds to 1 minute, then silanization, bonding agent, and lutein composite is put it into. So quite different. Here we see ultrasonic bath. So after our restoration is etching, the surface is rinsed and dried. However, the semi-microscope studies showed that even after the etched surface is rinsed with copious amounts of water, a great number of acid crystals still stay deposited on the etched surface that may affect the bonding strength. In order to eliminate these, the veneers should be placed into the ultrasonic cleaner. All residual acid and dissolved debris can be removed from the surface of etched porcelain with an ultrasonic in cleaning in 95% alcohol for 4 minutes or acetone or distilled water. Here you see the picture. 37% phosphoric acid is applied on the prepared area, and since the dentin is already sealed, the edge will clean the bonded area. It will also create micromechanical porosities of the enamel. Notice that a transparent strip protecting the antiacid canine, so not to be etched. And after the carrier of the primer has evaporated, adhesive is placed all over the whole prepared surface with a brush, giving it a shiny appearance. It is important that the adhesive is not light cured at this time. And after the inside of the veneer is loaded with the translucent lutein resin, it is brought next to the tooth with a sticky pole, like the picture B shows you, one slightly seated from the incisal comber. It is then pushed apically and palatally with the gentle finger pressure. The excess lutein semen resin should be seen on all the margins, confirming that enough material is used. And when the veneers are completely seated, they are spot tacked with a 2 mm turbo tip centered at the middle 1/3. Notice the still soft conditioning of the non-polymerized lutein agent around the margins, owing their ceramic thinness. It's about 0.3 to 0.5 millimeters, so it's very, very thin. The porcelain veneer can be easily fractured before they are even bonded, similar to the kitchen or bathroom tiles. However, once bonded on a solid foundation, they integrate with the tooth structure and become extremely durable, in vitro and in vivo. So, if all conditions have been adhered to, the appropriate bonding composite has been selected, the dentist will achieve successful results. Here is light curing of the cement. And here is finishing and polishing. So we have diamond paste, we have diamond drills with gentle grit on it. And here the final effect. So healthy teeth may be disproportionately aligned and so many not display their optimal aesthetic appearance. A new smile design, the irregularities of the soft and hard tissue have been corrected. The dark buccal corridors are eliminated with slightly over-contoured porcelain laminate veneers placed onto the premolars. Balance, symmetry, and an improved arch have been successfully achieved. And perhaps one of the most important advantages of the porcelain laminate veneer is that the periodontal reaction is really minimal. The smoothly finished margins help to maintain good periodontal health and oral hygiene. Okay, and thank you for attention because this is the last slide. So now I propose a 20 minutes break, then we are back and I display some video of the preparation. So thank you and see you in 20 minutes.
step. حاجة تانية.
A few moments later.
Okay, so that was everything that I've prepared for you today. So thank you very much for your attention, for your presence. Please don't log out, I will finish the meeting in a few minutes. And we see you tomorrow.